statement. Big and bold. Love it.
All right, good morning, everybody. It's November 5, 2025. The year is coming to a close, and we welcome all of you to our STED Talk. Always spell out the acronym. STED stands for Spine Technology Education, and the D is multidimensional, as the D implies. Discovery, discussion, discourse, and today's topic about bone healing with newer biomaterials under avoidance of biologics or minimization of biologics of heterogeneous source is the topic, and that's a really big deal for fusions. We're very honored to have Dr. Jessica Stark here, a neurosurgical colleague in UT Health in Houston, I think at Memorial Hermann, if I'm correct. And we thank DePuy Synthes for their sponsorship of today's event, and we especially thank all of you for your attendance here. Dr. Stark, are you live?
I am.
Good morning. How is everything in Texas?
It's getting colder, so it's nicer.
Okay. All right. Well, it's really drizzly here. So, so we got some cases first, and then we'll want to hear you talk about how fiberglass can heal bone. Oh, you got your cap on and everything. You're ready for action.
So
I already did a couple of cases already. So
Jens did his residency in Dallas. So he's a huge under the radar Cowboys fan.
Yeah, no,
that's not good.
New England
she's
guy.
a Texan.
Yeah.
Jessica, you're a Texan, probably not a Cowboys fan, right?
I'm a Saint fan. So
He's actually a big Patriots fan.
So yeah, but Rod does not understand how big Texas is and what a massive cultural divide there is between Dallas and Houston. So we'll have to sit down. You have to invite him down there to see just how big Texas is and have him drive from Houston to Dallas. So
Houston is huge.
yeah, so but it's great to have you here. As always, we want to start you with some cases. There are no tricks in there. They're commonplace clinical problems that we contend with all the time. And I think Dr. Mohsen Karami is going to take the lead on something. And Mohsen, take the stage here. So I think we have 4 cases. Several I don't know, but this one I'm familiar with. And I can't get into presenter's mode here, so I'll need Ben's or Corey's help here. But thanks for your attendance. And again, case number 1 will be presented by Dr. Mohsen Karami. iWorks, LA, iWorks. Nice. The funny thing is, thank you, Corey.
I really like them.
The funny thing is, I'm just gonna get these same glasses.
They're big.
Good morning. This is one of the cases we done like months ago. It was 83-year-old male patient. He fell in bathroom and then landed on his back and brought to the ED for back pain. So as you see here, he had multiple comorbidities like hypertension, essential tremor, morbid obesity, and hypoventilation syndrome. He was already on BiPAP and gout. And in terms of social history, ex-smoker, no alcohol abuse. In terms of physical exams, yeah, he was HGIE. There was no motor or sensor deficit on physical exam. Negative Babinski, no bladder or bowel issues. So we did a CT scan. It shows there is like a crack in T8, starting from anterior and into the posterior. And this is MRI. And this is the cervical and the lumbar areas, the CT scan as well. So in summary, the patient was 83-year-old. There was like T8, aortic B3, anterior tension band fracture, HIE. So in terms of plan, the question was to do like conservative treatment or surgical, doing posterior fixation, doing percutaneous fixation or open reduction and fixation, fusion levels, and then posterior only or 360 fusion. That was, they were like our questions.
Brace.
Say what?
I said brace.
Brace. Dr. Stark, We're not a trauma center here. We're not rated for any trauma. We're a stroke referral center, but trauma is not. We have a number of level 2 trauma centers, and whenever something gets in our healthcare system, whenever something gets a little bit more difficult, they like to send it to us. I'm sure you send this all the time. I see this all the time. These are these octogenarians, plus minus a decade, who are actually, as was the case in this individual, very functional. He lives independently. He had some new blood pressure medications. He passed out. He banged his trunk pretty violently against a bathtub rim, passed out, and was sent to a level 2 center of ours and then transferred to us because, quote, the fracture was too difficult. He obviously has an ankylosing spine disorder, and I'll just editorialize. This is on the margin between DISH, so disseminated idiopathic skeletal hyperostosis, but it does have some ank-spon features, mainly the thoracic spine, not in the lumbo-pelvic junction. So neurologically intact. And so Dr. Karami he's done a very nice presentation, but he's not identified the psychosocial aspects. Independent living, very functional, driving his own car, signing his own checks, pretty obese, severe pain, cannot be rolled in bed, has this minimally displaced, and I really appreciate the O classification, thank you, AOB3 hyperextension injury. What to do?
Yeah, I mean, we see these all the time, right? He sounds like he's not that sick for 83 years old, and he sounds pretty functional. So in this type of patient, laying in bed for 3 months is not going to be good for him. So yeah, I would typically do a perc fusion because it's like a long bone fracture because of the ankylosing dish component to it. So given that, I would do a percutaneous. Probably 3 above, 3 below because of the ankylosing spondylitis. Otherwise, you could just do a shorter construct. But I mean, he's got likely another 10 years to live, and he's not going to be able to get out of bed for 3 months with this, not really be able to move, and that's going to lead to further deterioration if you don't do anything. If he was significant comorbidities and maybe not so well off and not able to take care of himself, that's when you kind of talk about maybe just putting him in a brace and talking about considering the hospice type component for this, just because it could lead to a detrimental injury if you don't fixate this.
So Dr. Askuyan, our chief of spine here, has immediately said brace. So this is a man who has a very large barrel type trunk. And so typical dish appearance, dish phenotype. Why a brace, Rod? I mean, he's neurologically intact, but barrel shaped trunk.
So Jessica, I have a little bit more gray hair than you. When you get to be 80, I think the risks of surgery are pretty significant. And I think the guy next to me actually published some seminal articles on ankylosing spondylitis and the comorbidities. I think the complication rate was about 100%.
Not that bad, but yeah.
It was pretty high. I just think, for me, I would consider conservative management.
Trigger finger.
I've had some of the, I think they're in the gray, let's put it that way. And I don't, because of the fact, what worries me about this guy is the fact that he's not really doing much. Is it because is it because of the pain or because he's 80
pain
and not getting around? So
severe.
I don't think it's wrong to do surgery because that fracture has kind of opened up some. But I've also braced some of these sicker patients. So I don't think we have a clear, but I can tell you that the complication rate is not going to be 0.
So the posterior.
Wait. So Dr. Stark, do you have a repartee for this? So Dr. Askuyan is for kind of careful process. Here's the MRI scan, typical hyperextension signal, edema, no significant epidural hematoma. He truly hurts. Again, this is not trivial pain. We're not talking about a little bit of a backache here. We're talking about severe pain, significant opiates, just to roll him, and he does not tolerate sitting up. We actually tried to sit him up. I don't think we got upright x-rays, right?
No.
X-ray. So we did not get upright x-rays. It was going to be a futile point. We actually did get him a TLSO kind of a brace just to give him some trunk support. And I think that failed by memory. That was reliably seen on the side of his bed and not on him because he felt that it, quote, hurt more. So I think modified bed rest was one legitimate option. Bracing, we tried actually. We did not get upright x-rays because, again, we just couldn't get it. Rod, does that change your opinion?
I mean, I think, like I said, I think you can still brace him and see him back in clinic in 3 months. And if he fails, then you can always fuse him. I do like Jessica's perfusion versus open. I do think perfusion in a case like this is.
Yeah, I do a lot of these. We see them, a couple a month at least, if not more. And they're always on, upper 70s, 80s, even 90s. And it really kind of boils down to can they get up? Can they move without having a fusion done because of the instability and the pain? And what is their comorbidity? So you always have. If they have any heart issues or medical issues, we always have medicine to see them. And we always do the preoperative workup because it's not an emergency at this point, right? But what I found is, to put in some perk screws, it's minimal blood loss. It takes me an hour to do, 4 to 6 levels, depending on which ones we're doing. And they've done really well. I haven't had any significant complications from them. I've never had the screws pull out on an ankylosing spondylitis because their bone is, even though it's crap, it kind of stays in place, which is nice. But I have seen one where I braced it and it did fish mouth some more. He had just a lot of pain, so I ended up having to bring him back. And then I've had 1 or 2 that were really, really sick that I've braced and they did fine. So I do think there's a definite gray area. I think it really matters. Can they sustain surgery safely from their comorbidity standpoint? And then what can they tolerate in terms of if you don't fixate them, can you get them out of bed, or are they going to be sitting in bed and worsening their overall condition anyways?
So this reaction to percutaneous, I want to explore that. I'm an older guy. I don't have the gray hair to that extent yet, at least not that I acknowledge. But there are only 2 articles that I know of. One was by Dekutowski, and that was during his Mayo times. This is like almost 20 years ago now. And the other one was by John France that I remember. And why percutaneous? What's the fascination of percutaneous over open?
So in a really sick person or a very large person, it gives you a lot of advantages. So blood loss is significantly less. So stress, the increase in the inflammation, the lactic acid, all of that during surgery decreases all of that. In terms of healing for a wound for a very large person laying on their back on a very large, kind of 10-inch incision versus some small little 1 centimeter incisions, healing process a lot easier and a lot less risk of infection. And then just a really large person, that dissection is not fun, right? So you can do a percutaneous screw and you're not really worried about how deep they are because it's just a screw doing the work for you.
All right, so Dr. Karami with his trigger finger showed what we did, but we did it open, and I just got by, so go forwards. We did this open, and I do a lot of revision surgery, so I'm the reviser of things, and I see percutaneous screws that are being done that have failed, so I have a highly subjective negative bias. But if you give us some of the surgical parameters, I can give them to you. I think 200 cc's blood loss, and I think it was under 3 hours surgery time. And so the drum roll part, and again, this proves absolutely nothing. I realize that, but I found if you do the right dissection technique, have the right closure technique, this is actually arguably as fast, I'm not going to claim faster, but as fast as percutaneous with mechanically potentially better screws and actually surprisingly less soft tissue trauma in terms of trying to pass these rods, which can be hard. We did accept a slight hyperextension. We do these on a Wilson frame and just fine adjust the frame. How did he do, Mohsen? You saw him in clinic.
They're doing very good, no pain at all.
So the key thing from him was, and this is again a very lucid man, he told us he was just for his 3-month-ish follow-up. He said the second that I came out of surgery, I had no more pain in my back. So the mechanical stability is significant, and we did feel that he was pretty unstable. Again, we didn't jump into surgery. He was on the usual anticoagulants, but we waited for a while. We had to wait for like 3-4 days plus where we observed him, got him off his whatever, DOAX or whatever he was on, and had medicine clearance, echo, all that. But the actual surgical course was anticlimactic. The family was all around when it came to decision-making time, so they were there all the time. They wanted to know when we're going to do and what we're going to do and how we're going to do it. I told him the usual statistics, like in your octogenarian population, you have a 1 in 3 chance of dying by year 1, just simply from adjuvant problems, usually pneumonia or other stuff, not directly spine related, indirectly more. So this went quite well, and again, that's my go-to, and I hear all the things that you're saying, but again, I have a shaded view simply from the amount of revisions that I had to do from percutaneous fixations.
Jens, just out of curiosity, what did you use for bone graft? What levels did you fuse with the arthrodesis? And then why didn't you put a screw in the fracture level?
So the last I can answer easily. That's fractured. There's mush in the front. I could put pedicle screws in it, but this is not a burst fracture.
Yeah.
I think I completely agree with Dr. Stark. Multiple levels above and below. We actually coincidentally said the same level, suggesting 3 above, 3 below. That's mechanically a very nice fail-safe. We put the largest possible screws in. He had very small dysplastic pedicles, as it so often happens. We actually just used local bone graft, and we had to just fuse, quote, fuse 1 level. That's that fractured level, that's T8 level. So that was it. There was no other bone graft use, which leads me to my question to Dr. Stark. So you're going to talk about fusion later today. I think we all agree, if we could bottle whatever goes on in Angst-Spond, that would be quite cool. What is going on in these patients that lets them heal so well?
I mean, they obviously form bone on their own, just from the natural process of the inflammatory spondyloarthropathy that they have. So, I think, that's in our favor. If you can improve angiogenesis, which I think is what's a lot of this is going on for these patients, then I think that's what kind of stimulates the bone growth the best.
Yeah, no, that's obviously the big thing. And then the second question that I frequently have, so we gapped him open a little bit in the front. Assume again, I think you get a gestalt of this on the x-ray, the lateral especially. He has a large barrel-shaped trunk. We had a little gap in the front. We got a CAT scan afterwards. Does that require a graft? Do we have to do a secondary graft? Or we definitely gapped it open more than what he presented with. Should that be grafted, or does that fill in?
No, I think that just fills in. I mean, almost all of these, I feel like even putting them on the Wilson frame, it's so hard to get them to close down because it is kind of this long bone structure. So there's oftentimes a gap there, and that just kind of scars in, fills in, just because it's, the kind of the cancellous bone opposed to the cancellous bone. And even if there's a little space there, it will fill in because there's no movement.
Couldn't agree more. So yeah, so we agree largely. We did not agree on the approach, but again, I just wanted to point this out as to the miracle of bone healing. And again, if you could bottle whatever's going on there in a syringe, that'd be pretty cool. Mohsen, any thoughts from you? And you wanted to go anteriorly on him also, I remember.
Wow.
No.
Yes, you did.
I mean, because, the posterior elements
impressive.
were like intact. The posterior elements were intact, so probably braced is a good option. But most of the time, these people they come to the ED with no neurological deficit. But when we start the conservative treatment, they end up with a neurological deficit.
Yeah. So we did a screen of the whole spine. So this is just a common thing. And again, I think there's a little contention that if they don't mobilize well, and again, we've had those that mobilize very well and are braceable, we would treat this non-surgical because it's expected to heal, start bonding by about 3 weeks, and they have an unusually good, robust, inflammatorily mediated bone healing response, which we still cannot replicate in our in vitro environment. Thanks, Mohsen.
Thank you.
We'll come to Dr. Mohammed El-Hoshiemi next. He has a case that I don't know of, so it'll be a little bit of a curveball for me, maybe. And Mohammed, Dr. Karami originally came from Tehran, and he's been in Canada, and he's now with us, and we enjoy having him. And just as much we enjoy Dr. Mohammed El-Hoshiemi. He is from Beirut originally, and he has a case also from the more recent past, right, Mohammed?
Yeah. So good morning, everybody, again. We have this case. We actually presented this case 2 weeks ago. This is a 60-year-old female, myelopathic radiculopathy in 2021, treated by a multiple level ACDF by another surgeon. The patient presented to clinic back with severe neck pain, tingling in the right C8 distribution. Patient has a significant past medical history with bipolar disorder and multiple other comorbidities. Her exam was significant for weakness on the right side, 4/5, the distal hand movement, and in the grab. the grip, sorry. And this is her MRI. So the previous ACDF was done here, C4 to C7, and we appreciate this C7 T1 massive disc herniation with significant foraminal stenosis on this side, compressing the C8 nerve root. The patient underwent a posterior foraminotomy and a laminotomy with an attempted discectomy. This is the area of the bone what was planned to be removed. And this is the post-operative MRI. So the patient had a good post-op outcome, was fine. She reported improvement for a few days. She left home and she had a fall at home where she landed mainly on her left side, and she came back in with severe worsening neck pain and the worsening weakness on the right side. And this is her MRI, her CT scan post-op, post-fall, sorry. So as we mentioned, we have this anterior fixation. Multiple findings we noted on this CT scan. We had this area of C7 facet resection, and we have also some findings on the posterior side, some widening of the interspinous spaces. We had like a fracture in this T1 spinous process. And this is her MRI. Again, we noted some edema in the interspinous ligament and this fluid collection that might be a liquefying hematoma versus a CSF collection. We saw the patient, and again, this is very important image. We see the extent of facet resection that was performed, and the very small remnant of the facet was there on this patient. Patient was in severe pain. Her weakness was very pronounced, and we went into this big discussion with her. So again, 60-year-old, bipolar, ACDF, 1 week post-op for C7 T1 laminoforaminotomy. She had a fall and these findings.
So
What's
this
your
is,
concern?
yeah, so the nice succinct presentation. This is the reality number 2 of trauma care nowadays, spine trauma care. This is a trauma that occurred in conjunction with a previous surgery. This case, both a fusion above and a decompression posteriorly. So whilst we have this here, let me ask you, Dr. Stark, what is your go-to fusion construct for a multi-level ACDF? A very innocuous question. When you do a 3-level or more ACDF, what is the best material to use for the front of the C-spine? We want to obviously be very cognizant of identifying possible off-label applications of certain substances. So what's your go-to biomaterial to achieve a good, solid, multi-level anterior fusion?
I mean, I just used kind of the standard titanium 3D printed cages now, filled with right now FIBERGRAFT, but you know, any of the allograft spacers. I also, for certain patients, depending on if I need like a hyperlordotic, it would be more of the allograft spacers alone with the plate and screws. I don't typically do more than a 3-level, just because of the dysphagia risk. It's got to be a guy with a pretty big neck for me to offer a 4-level ACDF.
Yeah, so that's a great answer. I think the surgeon in question, this is interesting how these things come back, uses a low-dose BMP. This is off-label, and it's actually a black box warning because of dysphagia risk and substantial retropharyngeal swelling. So talking about inflammation. So BMP is phenomenal. It leads to bone healing. And I'll be curious to hear your thoughts later about FIBERGRAFT versus bone morphogenic protein variants. But here we had a previous ACDF augmented with low-dose BMP, and now the 100% event happened, the disc below has failed, and here we are. So we have a mechanically unstable situation. Your thoughts about re-intervening in the front and then solving this problem? So obviously the surgeon in question did not want to go into his own previously operated neck again and fix that. But if this was your patient and this patient now has a significant clinically relevant disc herniation below, how would you handle this? Front, back?
Yeah, so if I don't put BMP down. I agree. If you put BMP down from the front, going back into the front is almost a complete no-go. I mean, we've seen it on posterior fusions, how much it changes the tissues. The esophagus gets really scarred. There's lots of an inflammatory process. So I would not come back in through the front if someone had used BMP. That's just my personal opinion on type of, risk and increasing again dysphagia because of how much of an inflammatory process happens there. If I had just done one of my normal, 2 or 3 levels and it was an adjacent segment disc, I would go in through the front again because in theory, this is just excess stress on that level. That's why you have the herniation. Now, if we now come in and someone had done the posterior like this, I would fix this from the back now, if not front back, because there is no facet there. So you've got, kind of an unstable disc in the front, you've got an unstable posterior. So now you really almost have like a 3-column injury that's kind of iatrogenically created at this point.
Couldn't agree more. So yeah, this is a very difficult situation. And we actually also have a CSF leak from the previous posterior decompression. So we have like a worst case scenario. We have, you called it, it's a 3-column injury. So anterior column is no longer weight bearing, posterior has, and there's a large disc herniation. We'll call it residual versus recurrent. We will not label that any further. Patient has severe radiculopathy, no myelopathy, but clearly positional headaches, can't get up. We actually put her into a brace when she came to me, to our service, and Mohammed was so kind to see her with me and labor with her for a while. But so concretely, what would you do now? Would you go front and back? Would you try to fix this all from the back? What's your suggested plan?
Yeah, again, with the BMP, I really would hate coming in through the front. I can't really tell if it's just that foraminal disc on the MRI. It doesn't look like there's a ton of a central herniated disc there. I think it's mainly off on that right foramina, or there's a little bit of central. So you've already made a big, nice, wide opening and taken off almost all the facet there. So I do think you could potentially take out that disc herniation from the front. No matter what, I would definitely do kind of mirroring the front and the back going up. I would probably do a C2 to T2, or I would at least go to C4 and just kind of mirror the front down to T2, because you can still get a screw in at T1. It looks like, even though the top part of the pedicle looks like it may be drilled down a little bit. And then, I think an option would be a flex X to see if there is any mobility in that front, because it is kind of compressed down and it looks like all the disc has been pushed out posteriorly, to see if you would need to do anything there too.
We concur on all fronts except ... Dr. El-Hashemi, what did we do?
So there's something I missed in the history. The patient was also operated on a thyroidectomy. So her both sides anteriorly were scarred. After significant discussion with the patient, we decided to do an anterior posterior surgery. We did a right carotid style anterior revision. On the right side, we did an ACDF C7T1 with a structural allograft, 9 millimeter graft with no plate. And then we flipped the patient. This is the X-ray, sorry, this is the allograft. Sorry, the X-rays are not very clear. This is the distractor here. We try to distract and release this 7-1 level as much as possible. And this is the allograft at the C7T1. And then we went back C4 to T2 revision with the right hemilaminotomy, and we explored the area, local bone graft and allograft. And this is the final construct we got. This is C4, and this is down to T2. Patient post-op did very well. Her pain directly improved after the operation, and she was kept in the ICU for 1 day for monitoring, and she was discharged later on with no issues.
So we went front and back in defiance of your suggestion, but let me tell you that my interest in going in from the front again was very minimal. Dr. Skuyan always likes to give me grief, and he's pulling the microphone close to himself because for these more complex revisions, especially with previous BMP, I do like to make a longitudinal exposure and carefully expose the neurovascular / mediastinal interval. And I must congratulate Dr. El-Hashemi and Dr. Amsta Khan, who did this exposure beautifully for a very clean dissection. Rod, overkill, underkill?
No, I mean, honestly, you can see there on the AP, I think, you got a beautiful structural allograft and it's going to fuse. I do think that's probably the most critical part about this case. The one thing, Jens, which you briefly touched about, but I've had a couple of these. How was the CSF leak repaired? Because that could be long-term a disaster.
Totally agree, and we were prepared for everything. We actually, I think, just put some Tisiel on it and put some Surgicel on there. This was a non-factor. The best thing really was coming in from the front and getting that centrolateral disc herniation out, starting from the less involved side. So in this patient, I think it was the left side that was the less involved
The
side.
right side,
Oh, right
yeah,
side.
the right was the surgical part,
Yeah.
and the left side.
So
was
we
the
went from the
virgin.
contralateral side, established a plane to the dural sac under the microscope, and then the disc actually came out very nicely, right? We did
Yeah.
not have a
No issue.
huge technical issue there, establishing a plane with small neural dissectors, and we fished it out. There was a flush of some fluid. We thought, okay. We sealed that off with Surgicel. I think we put a little fat down and put Surgicel down. We put a drain in and did our posterior part. The posterior part did not have any big fluid flush anymore. We filled it again. Surgicel after wide feminotomy was done. You can see we literally did a lateral mass resection almost, and that was already done largely. We filled that up with, I think we used just local bone graft and allograft, right?
Yeah, yeah.
And we had an structured allograft in the front, so no enhancing substances. And she's actually done very well. Do you have a post-op CT or upright x-rays?
No.
That's okay. Yeah, but she's done very well, and we were able to realign her. But the point here is that, again, the discussion points for me are anterior cervical fusions, multi-levels. I think, again, Dr. Stark and I have a suspicious concordance on thoughts. I do not like and do not endorse off-label BMP for the front, and it clearly makes the revision anterior exposure very hard, or much harder, because it leads to this inflammatory process, which I think is a big deal in healing. And then if a patient has a 3-column injury, ideally we reconstruct the front column and the back. And in light of the fact that we did not want to take out the front plate, we could have, we just put a graft in, and they actually have held very nice, and then we compressed from posterior. Any learning points for you, Mohammed?
The learning point that I was pretty afraid of the exposure from the redo part. You can do it starting from the virgin part and going to the scarred part, and the use of the distractor is very important to release the whole thing.
How was it posteriorly? Was it pretty unstable?
Yeah.
Yeah,
She was
Because
a
it
true,
looked like it was.
she was an AO type
Yeah.
B2 flexion distraction injury, as Dr. Stark said.
Wow.
So any thoughts, Dr. Stark? Overkill? I mean, the patient obviously did well, so, but
No, I mean, I think that's what I normally would do. My only hesitation was, and especially with the thyroid and BMP and all of these things, going in through the front, I would have at least had ENT check to vocal cords to see if there was any dysfunction, since, both sides had kind of been affected and things. I think front back is a very reasonable thing here, and your alignment and correction was outstanding. So I think you did everything completely appropriate and right. Looks good.
all
That
right.
was not an easy case.
It was
by
not
the
an
way.
easy case,
Yeah.
no. It took about 6 hours, and
Jeez.
we
Wow.
did do a very cautious anti-exposure. And again, Mohammed and Hagai did a very nice job doing that. All right.
Thank you.
Thanks, Mohammed. Who wants to go next? Oliver or Hagai? We talked about Hagai. Let's stay with Hagai then. Hagai Amstakan. Great fellow. He's wearing the garb. Jessica, do you have garb for your fellows and trainees?
Not really. No.
I like the Seattle Science Foundation.
Yeah.
We're in Seattle after all. You don't need hoodies in Texas. You need cooling aggregates.
Yeah. Cooling vest.
No sleeve scrubs.
No.
That's what goes there.
All right, Amster.
Good morning. So I'll present another case we did recently. This is a 60-year-old male. He was involved in an e-scooter accident. He had a chest and a back contusion, and he showed up at the ED with progressive low back pain. He wasn't getting any better about a week after his accident. His medical history is significant for rheumatoid arthritis. He had some previous lumbar radiculopathy that was operated on. He had a LAMI and a discectomy at L3-4 and L4-5. Socially, he works as a technician. He's a physical worker. At the ED, his exam was completely fine. He had no neurological deficits. His lab work was also normal, and he was discharged with pain medication. He continued having back pain, and he went to his PCP, and he had repeat labs that showed a white count of 32. with left shift, and he was sent back to the ED. No fever, no chills, and again, his exam, no neurological deficits, but a lumbar MRI was ordered. On lumbar MRI of his spine, we see bilateral psoas abscess more on the left. We'll see it better on the axial view, and an epidural abscess and some edema behind L3-4 bodies, with some signs of L3-4 discitis, perhaps osteomyelitis. That was the first time we were consulted. The patient was stable. He had no neurological symptoms, and we decided to go with the conservative care. He was started on IV antibiotics. He had a psoas drain inserted by IR, and he was followed up by infectious disease and medicine. His cultures were positive for MSSA.
And the CT again shows what? How much osteomyelitis is there?
So at this point, we didn't have a CT yet. We have a CT in further on.
So, Dr. Stark, we have made some jokes about the temperature differences of the Pacific Northwest and Texas, and you're in an extremely humid hothouse climate down there. We are inundated with infections. I think it's fair to say, right, Harai?
Yeah.
Have you ever seen any discitis, osteomyelitis, epidural abscess congregation like this?
No, this guy he's still not out of it. He's having trouble. We'll talk about it at the end of the.
But just numerically, how many infections you see? I mean, it's unbelievable, right?
Yeah.
Yeah, I don't know what it is. So how bad is this for you as a clinical burden?
I mean, we see a lot, but I feel like we get an unfair, kind of share because we're really big. It's Houston. So, but I mean, I couldn't say more than probably 1 or 2 a week at least of some type of infection, osteomyelitis and discitis. Lots of dialysis patients, kind of the leading cause, but.
That's a good point. I think, yeah. So we've done a couple of publications about this now because it's so common. I'm not going to go into bragging whether we have more or less because it's just, but this is one of the banes of our existence right now, right, Dr. Kramer? I mean, he's a neurosurgical colleague who's joined us from the University of Wisconsin, the faculty here. How is this compared to Wisconsin, what we see here?
Yeah, I totally agree. I've seen a lot more infections here. Obviously, I think there's a little more drug use out here in the West Coast than there is in Wisconsin. I think that contributes to it. But yeah, it's pretty phenomenal.
Legalizing marijuana did not help.
Yeah, we actually published on that in Spine. First author was Bletcher, and he did a very complex, comprehensive state discharge database assessment. And whether it's coincidence or not, it coincides with the legalization of marijuana. And I was actually at the time by the editor-in-chief asked to write a stronger discussion identifying a causality, and I declined that. I said we cannot establish causality between coincidence and causality. This is inference, but I didn't want to get into a lengthy discussion about gateway drugs. The point is now, in retrospect, I have to say that most likely it is a causal connection, and it's an indirect one. When marijuana was legalized, the price of marijuana dropped dramatically, and this being a free market economy, this dropped the price of so-called hard drugs, so heroin, etc. The price dropped through the bottom, and suddenly very hard drugs became widely available. And that has probably led on that particular clientele to a much bigger pervasive problem. The concrete factor here is obviously there's some medical comorbidities. We have not only an epidural abscess, we have a discitis, and we have a very large iliopsoas abscess. So Dr. Stark, assume this is Friday afternoon, it's 5 o'clock. You're not on call anymore, but the on-call colleague is calling you saying, I am doing a lengthy case. Can you help me with this? What's your response?
Yeah, I mean, I think y'all did everything that would have kind of occurred here. So, he's neurologically intact. It's, not at the cord level. So I would have had a IR biopsy and drain the psoas abscess to get cultures, and then I would have started on broad spectrum antibiotics and give him a chance to see if this can heal without having to do further intervention.
All right.
So yeah, we followed up on him for another 2 weeks. His kidney functions, which were also high, and white count were trending down, but he continued to have severe back pain. He was almost unable to leave his bed because of the pain, and he started having some left lower extremity weakness. The repeat MRI wasn't as different from the first one.
Did he have an IR biopsy of the psoas abscess?
Yeah, he had a drain in.
In the
which-
psoas?
Yeah, in the
Okay.
psoas, and we had cultures from the.
Okay,
It was MSSA. Then we got a lumbar spine CT, and you can see the degenerative changes at the L3-4 level, some erosion of the end plates, some listhesis. And due to his worsening symptoms and the failure of conservative care, we offered him surgery with debridement. But that's basically the question now. So to summarize, a 60-year-old male, L3-4 discitis, osteomyelitis, a small epidural abscess, psoas abscess, some left lower extremity weakness. What are your ideas?
so 2 weeks now, something like that, since presentation?
Yeah, about 2-3
Failed
weeks.
IR, no focal neurology, I would put that as a plexopathy, no cauda equina, right?
Yeah, no.
He has been braced, I assume, right?
Yeah, but he was in severe pain.
Yeah, so again, non-responsive to bracing.
Yeah.
What do we do now, and do we have to do a fusion or as a decompression of Dr. Stark?
Yeah, I mean, did we do any FlexX imaging to see if there is kind of a mobility at this level, given the discitis degree?
I was not the attending
No,
on this, right? Yeah.
we don't have any FlexX imaging.
I look at the sagittal that Hagai has shown us here, and it has a facet diastasis. So
Right.
in principle, I love those, but maybe here, if this patient can't get into the vertical, I'm going to forego a flexion extension film personally, but that's just me.
Yeah. Yeah, I mean, I think in 2 weeks, if the MRI looks relatively similar, but his symptoms are getting worse, I would offer surgery. I would say, his facet is, like you said, splayed. He's probably got almost like a septic joint at that level too, given the amount of sprain, or at least an instability. So I honestly would probably decompress him, but lean towards maybe even cleaning this out and doing a TLIF at that level.
All right.
If
Yeah.
doing a TLIF, what graft would you use?
Okay.
Yeah, so I use, I don't like to put infected bone back in, so I actually don't like to use his bone from the local area, either allograft or a distant autograft. So
Distant autograft, allograft. Do you use off-label bone morphogenic protein?
I don't in infections, just because again the inflammation's already high. It increases inflammatory response at that level, so a lot more fluid, things like that. So I typically do not use BMP in an infection risk.
All right.
Okay, so that's what basically what we do. We ended up doing an L3-4 TLIF. We used the P cage, and we used, I see Dr. Chapman's nodding his head. I know you like using titanium. We decided to use P cage just to, in case we need to revise it, it may be easier to get it out. We used BMP to increase the inflammatory response and maybe burn out some of the infection. In regard of his back pain, the patient is doing much better. He's having problem with persistent bacteremia and he's seeding. He's already had a hip septic arthritis, knee septic arthritis, sternoclavicular septic arthritis. He's back in the hospital with the.
So I like to wait kind of 6 weeks anytime someone has an inflammatory kind of septic joint or discitis abscess before I put hardware in. Obviously, sometimes you can't wait that long, but it just does give them a little bit better chance of clearing the infection, I feel like.
Hagai, you didn't reference the site score. What
Our
was the
site score.
What was the site score?
We've published a site score for this.
Hagai, gosh.
Journal of Neurosurgery. Hagai, you got to self-promote.
Okay.
Lesson for our internal communications, Dr. Stark. So yeah, those are some interesting points. So I think that we agree surgery is absolutely necessary here, and a debridement and a 3-column reconstruction is perfectly good. We use a thoracoscopy irrigator from both sides and wash out both sides. Did you do that?
Yep.
Yeah, so you can get a very precise, high volume wash through with this. And did you use BMP in this?
Yeah.
Yeah. So the bone graft material here in favor of BMP is actually very high. And the evidence strength is empirically founded, so it's not great statistics, but it actually goes back to UC San Diego and Steve Garfin, and this is like a 20-odd-year-old article when it first came out, and you called it the pro-inflammatory response here is actually very, very favorable. The only thing I don't like is BMP plus peak in this setting, because peak does not allow for a fibroblast on-growth. It's like a wall, and titanium is actually very nice in this setting, but again, that's a finite point if you do a good debridement. And in this case, doing a monosegmental fixation is gutsy, but that's kind of cool for the patient if you can limit it to one level. Did you do anything special to get into the psoas abscess? Did you put any probes in there?
No, the psoas abscess at this point was drained with the drain that was inserted earlier on. So we just, we left it to be.
But actually, Jessica, I don't know if you guys get this, to put a little plug in for our site score, is that what we found, because we get so many infections, is you know how there's a SINS classification for tumors? There's always a debate, like ID's like, do LAMI, we want tissue, biopsy, but don't put hardware, right? So Jens and I and one of our previous fellows, Jonathan Plumer, went back and did a retrospective review. And just like tumors, you know, the location matters, neurology matters, you know, is it lumbosacral junction, cervical thoracic junction? How many levels? Is it discitis osteomyelitis? Is it just epidural abscess? So all these factors, you know, what are the comorbidities? So all these factors, because I don't know how it is in Houston, but here, it depends who the ID doctor that's on call. And they view spine fusions as like, you know, if you have a shunt, for example, they're like, we don't want hardware because it can get infected. Well, this is different than a shunt or, you know, a joint. So we kind of framed it based on that. I don't know how it is in Houston, but I think it's been really helpful for us because it gives you kind of a framework. And then if you have a certain score, then just like the SIN score, you're like, okay, these people are more likely to need to have a fusion.
Yeah, so obviously we don't have that article to show, but the one thing I'd like to add to that is that hardware and infections are actually not mutually exclusive. It's actually, when you have a good debridement, it's actually 100% safe in our series of several hundred patients to put hardware in. We actually did a systematic review also under Plumer that showed, and this is not just our center, multiple centers, that the survival rate and morbidity rate of patients with spine surgery and hardware is lower than that of patients who A, did not have surgery, or B, just had decompression. So we're not advocating for fusions for epidural abscesses and all that, but if you have an unstable spine, hardware at the primary surgery is safe and does not lead to higher recurrent infections. So that's just at least our purview. But yeah, I know there's a frequent instinctive thought of aversion of putting hardware into an infected spine. That's a naturally healthy instinct, but we found it in our experience to be not just safe, but actually helpful. All right, Hagai, any other thoughts?
Oliver? No, like you said, I think infections hate stability, and the ongoing instability in these cases also hurting the patient with pain, but also making it harder to get rid of the infection.
All right, thank you. All right, next we have Dr. Morzinski, a neurosurgical colleague from Penn State, and he's smarting from his recent football losses, so if he's more humble than usual, it's in reflection of his bad news on the football side.
We can talk about that offline, maybe. So my case is on this patient that we saw that had another infection. So this is a 61-year-old morbidly obese male, history of diabetes, hypertension, cirrhosis, alcohol abuse, already shaping up to be a great operative candidate. Presented to a local hospital. He had ultrasound sensorium. He had a severe back pain, severe anemia. At the Edson Hospital, he was found to have some esophagitis and GI bleed. He also had fevers. He had a high white blood cell count at the time. His exam was just this kind of this diffuse weakness throughout. He was in terrible pain, couldn't move in bed. He was hyperreflexic, not of a Hoffman's. Babinski was present and he had no beta-clonus. Due to his back pain, his fevers, CT was done, and this showed suspected spinal osteodiscitis. And with that, he ended up getting an MRI of the cervical, thoracic, and lumbar spine, and he had this very large ventral and dorsal epidural abscess that extended from T1 all the way down to the lumbar spine at L5, with multiple levels of discitis. And here are some of his pictures. Obviously doesn't have the best looking cervical spine as well, degenerative wise. Hopefully this will play here. So you can see down that T1 level as well. Here's his thoracic spine. So scrolling through, you can see the spinal cord is compressed dorsally, and then on that axial, you see just diffuse ventral epidural abscess causing significant compression of the cord pretty much throughout. And then this is the scan with contrast, the thoracic spine. So just a terrible, terrible diffuse abscess.
Wow.
Here's his lumbar spine. Again, diffuse abscess, pushing the roots posteriorly. You can see that on the axial there, not the best quality MRI, but that's just what we had. And you see at L4-5 especially extremely, extremely stenotic. So this guy, 61-year-old male, obesity, diabetes, alcoholism, cirrhosis, GI bleed, terrible back pain. He had diffuse weakness throughout, and he had this obviously diffuse, mostly ventral epidural abscess from T1 down to L5. So what's the plan here? How do you attack this? Do you just unzip the whole spine? Do you need to fuse this? What's the plan?
Dr. Stark, are you laughing? Or has your pain of nighttime call been diffused a little bit because we share the pain? Any reactions?
I mean, I literally just had a guy like this last week when I was on call, or 2 weeks ago when I was on call, and it was similar. And it was actually almost an emergency. He came in, he had lost function at an outside hospital while they watched him for 3 or 4 days, and he had an epidural abscess from basically C2 down to L1. And I did take him emergently and unzip his spine. For these, I typically do like hemi-lammies, like every other level or so. So I don't take the bone off all the way, but I do open up and kind of, because just doing individual incisions take forever. So we did that, and the guy actually went from almost an Asia A, not moving anything, to he actually regained all his sensation and regained significant function in his legs and one arm. The other arm still remained pretty weak, but that's a little bit unusual. They don't usually come in completely out like that, but not fun.
So if we go back to that MRI of the thoracic spine, I think we can all agree that once the cord level has an epidural abscess, especially one that is anteriorly and somewhere posteriorly, that's a problem. But I want to direct you to that T6-7 area. So one question that has been unresolved is the etiology of epidural abscesses. And we obviously know of thrombosis of epidural veins with a septic bolus in there. The other one is discitis, and again, it can literally, like a hydraulic pump, when the patient loads their disc space, push epidural abscess into the epidural space. So is this a concern here? Dr. Kramer, I think you were the attending on call for this? Or was it Dr. Abdul-Jabbar?
Yeah, this was my present for Monday morning, starting my call week.
I think Mark stole this case.
He asked for it.
Yeah, so just to add a little bit to the history too, I think he initially presented with a very significant GI bleed, and he was intubated, had an upper endoscopy, and so he was already intubated, and then initially shipped to another hospital. A local spine surgeon there thought this was a little maybe too complicated for their facility, so that they got sent down to us. And yeah, I think, you know, when we looked at him, it's hard to get a good exam because he was obviously intubated, but we did feel that he was having some significant weakness from this, and he presented, like Oliver said, with significant back pain. So we felt that, you know, taking care of this urgently was warranted. And the thing that also made this really challenging is that he's a rather large gentleman. He's well over 300 pounds, and he, despite our best efforts to resuscitate him, his INR remained somewhat elevated, and you know he had been drinking up to the day that he presented, so he had some liver dysfunction. You know, it was a challenging case. I guess go into what we did. Our plan was similar to what you had described. We were planning to do skip lamies all throughout. So both Oliver and I, we scrubbed this case, and we kind of started off at the top and bottom, and literally within the exposure, I think we lost almost a liter just because he was a huge guy. We couldn't decompress his abdomen all that well. So we were already kind of struggling with the blood loss. And once we were able to get the L4-5 laminectomy done, and then we did some skip lamies at the top, we actually were able to get down to the ventral abscess, and we put some ventriculostomy catheters at both sites, and we're able to flush across both sites. We're able to kind of clear up that ventral epidural space just with those two kind of laminectomy sites. So we talked about actually doing an additional lami kind of the mid-thoracic region or even the thoracolumbar junction, but just given how much blood loss we already experienced with the initial exposure, we felt that, you know, maybe better to do less than more at this point. So he's doing okay at this point. He's actually moved out of the ICU at this point, and he's moving his legs okay, but we'll see how he does.
Did you do any repeat imaging, like a repeat MRI or anything like that?
Not yet.
What caliber EVD catheters did you use since you had cord level?
So we used the trauma catheter.
Okay. So what French is that, just for everybody's education?
Actually, I'm not sure what size the trauma.
They're actually not small, but they're, I think, Rod, do you remember the name, the number?
Like a
For the EVD, the trauma EVD?
You know, I don't remember because we just have one size, really.
I think it's an 8, something
Yeah,
like that.
but-
Oliver, so how did the patient do then? Did okay?
Yeah, so as Dr. Kramer was saying, I mean, for me, it was a great learning case because I think if I had seen this initially, I would have done many more levels of laminotomies than we did. But, you know, we prepped out the whole thing with the plan that if this was phlegmon or whatever, we would have to just unzip him top to bottom. But it was pretty impressive that we were able to just do lamis at the top and then kind of a bigger lami at 4-5. And then as it was amazing. I mean, a significant amount of pus came out. It was like pimple popper for the spine. It was unreal.
Okay.
But then when we flushed the catheter, you know, when I started down to the lumbar spine, we were able to get fluid going all the way up to the thoracic and vice versa, which was to me very impressive. I've never seen that before. So definitely the longest or furthest skip lami epidural abscess I've ever done, and we were able to get clear fluid going top to bottom by flushing from both sides. And so, you know, obviously we both felt there was no need to do any more lamis in the middle of the
Impressive.
surgical field. So it was a good case. It worked. It went
Dr. Stark, follow-up. So I think lucky here is a liquid abscess. I think we have a strong concurrence. Any thoughts in terms of follow-through, and especially in light of that discitis that the patient had, at least at, if memory serves me correctly, is T7-8?
Yeah, I mean, I agree. I think that's a great way of doing it. I usually start at the top and bottom when I'm doing this kind of wide exposure and start going up, and I usually go every third level. So kind of similar. I would have probably done a middle one, but except for the fact that you were able to see that clear fluid coming out, which means, you know, it was washed out pretty well. So, I mean, that's fantastic. For anyone who has an osteomyelitis, I get close follow-up x-rays, standing x-rays if they can, usually at 1 week, and then I go to 2 weeks following that. And then if, they're staying stable during that time, we're kind of at the 3-week mark, I'll go to, around 2 to 4 weeks for the next x-rays, just because they do have that high potential to collapse in the very beginning. Once they start scarring down and the infection's going away, it's less likely. But I do think early repeat x-rays, particularly standing, if possible, is really important.
All right, I think we're at time for our case presentations. Oliver, thanks for this presentation. Kudos to all of our fellows. Thank you. Dr. Stark, great to have you here this morning. Thank you again for taking the time to speak at our STED Talk. Dr. Jessica Stark is a fellowship-trained spine surgeon, and she's done both spine and cranial surgery training. She got a medical degree at Louisiana State University in New Orleans. She was Alpha Omega Alpha, did a residency in neurosurgery at McGovern Medical School at UT Health. And she also has a master's degree in public health, which I think is fantastic, with a socioeconomic fellowship. We certainly saw some practical challenges in terms of socioeconomics in our clientele here today, and it's to veer into that realm quickly, it's a public health problem. Bone healing and the health of our patients are major challenges in an impaired spinal column, and it's very cool to have an expert like Dr. Stark talk about modern implants that we can use to augment bone healing. And we showed a couple of clinical case scenarios which have been challenging, and they're just from the last couple of weeks, with the exception of the Ang-Spon patient, which was 3 months out. But this was hopefully a little teaser potpourri as to the clinical challenges we face all the time. Dr. Stark, look forward to hearing and learning from you. Thanks for being here.
Thank you all. I appreciate it. Thank you to the Seattle Science Foundation and to Diffuse Synthes for allowing me to present this to you today. So I'm going to share my screen. Can you all see my screen?
Yes.
Okay. So I'm just going to talk a little bit about kind of the future of bone grafting, kind of my journey through using now what's called FIBERGRAFT Bioactive glass, also known as Iridian, as its kind of newer form. I actually did my thesis during my public health master's on biologics and bone fusion. So this was something that's always been kind of an interest of mine, kind of coming through residency and then, through my master's. So I was kind of excited to have this talk. So see if I can advance the slide here. Sorry.
Uh-oh.
Mm,
Refresh cycle.
Yeah, hold on. Come back through. Come back up.
What's the machinery you have behind you there? You're sitting in front of a big piece of equipment.
Yeah, that's actually the telegen and stuff is here. So I'm outside the OR. I'm doing cases. So all right. So can we see now? Is it sharing?
Right now, we don't see your slides, so we have your camera view.
Let's see. All right.
Excellent. And
Good.
now for the presenter view, yes,
Yep.
it's your
Okay.
pro.
All right.
There we are.
So yeah, just my disclaimer here. So I am presenting this on behalf of Johnson & Johnson Diffuse Synthes, and that's really it. So so this is just a kind of a little bit about the evolution of synthetics. So synthetics, kind of our original calcium phosphates and sulfates, were developed back in the 1990s. They really weren't that popular when they first came out. So the fusion rates were a little bit lower. And that was kind of your original VTOS, your nanos. And then in the early 2000s, they started changing it and adding bioactive glass to these. And we'll go into a little bit about kind of what all that is. So that was your VTOS second edition to the BA, the biospheres. And then FIBERGRAFT came along kind of after that with the glass fibers, which really kind of changed the structure of the synthetics. And then with the newest in 2021 is when they released the Iridian FIBERGRAFT, which is the boron bioactive glass component, which has really added some extra benefits to the original kind of calcium phosphate sulfite synthetics that we had on the market. So the fusion rates, as you'll see, have definitely increased and changed from the original synthetics that we had. So Iridian Matrix is the first bone graft substitute that contains boron-based bioactive glass with some other essential elements. So it has magnesium, zinc, copper, and boron all in it. And then the structure having that kind of type 1 fibrillar collagen structure makes it really easy and kind of honestly, it's just ease of use in the OR. I like to cut it in a strip and then lay it down on either side, and it works well. So, why is the boron, different? What does it do? So the boron really enhances the osteogenic differentiation within the bone graft. As we mentioned, there's 3 other elements in here. So the copper, it's supposed to help the endothelial proliferation, which kind of helps with angiogenesis. And then the zinc helps with the proliferation of bone growth and differentiation. And then again, magnesium is just kind of essential in the calcium process for the bone making and fusion process. So what the big thing, and we kind of alluded to this during the case, is, why does ankylosing spondylitis, have this, fusion process? And a lot of it, we really do think it's this kind of angiogenesis component that goes on. And that's why the boron is so important in this material, because it really does help promote the angiogenesis to help the fusion occur. So, you have the hydroxyapatite formation, and it really shown in a lot of the studies with the iridium that it's forming within 2 hours when they have it in vitro studies. So this was just a study that came out on the iridium matrix. It was a retrospective study. The limit here is it was only 31 patients, but they looked at the fusion rates, on x-rays and CT scans. And, at 3 months, it was 81%. At 6 months, they saw like 100%. And then at 12 months, 97%. There's a little weird that, at 12 months, it went down. Not really sure what that is. I don't know if they were saying on x-ray maybe at 6 months and then CT scan at 12 months. But, pretty great fusion rates for, almost 100% by 12 months. And this was presented at the Congress of Neurosurgery in 2024, this past year. So, it has some limitations, but pretty reliable given the fusion seemed to happen in almost all the patients. So then one of the kind of follow-up studies was they looked at BMP compared to FIBERGRAFT, and then the 2-year incidence of pseudoarthrosis with that. So basically, BMP we know is the kind of be-all of bone grafts, and the fusion rate and pseudoarthrosis rate is the least with it. So when you compare it to BMP at 2 years, there was 1.5 versus 1.6% of pseudoarthrosis. And I mean, that's pretty remarkable in terms of how close that is. And then when you look at the difference in the cost, BMP is on average, around, $2,500 more per use, which is a pretty significant cost difference, and also important when you look at kind of the public health side of things and healthcare cost for patients and the hospitals. So I'm going to go into show a couple of cases that I did with using these and the fusions, but any questions on any of that I can answer for you?
Yeah, so Dr. Stark, so thank you for this foundational experience. My first question is always, as co-chair of our Providence St. Joseph's Bone Graft Committee, what is the animal experience in this? So what animal testing was done on these to show the principal fusion mechanism and the basic physiologic integration and ossification?
So I'm going to ask Bobby or Matt to answer that for y'all from the Pew side, if they can answer that.
Hey, so I'll answer that. Can you guys hear me?
Yes.
So my name is Bobby Warren. I was one of the engineers that worked on the Iridian Matrix product a few years ago. But what we did was, in order to achieve regulatory approval, we did posterior lateral rabbit study. So the classic posterior lateral study.
Posterolateral fusion, okay.
Yes.
And so the comparison for that one in your hands was what? Was it a 0 model or was it autologous graft? What was the comparison?
Autologous graft and a 0.
Okay. All right. So that was favorable then, I assume, and it showed an ossification pattern. Was that a peripheral ingrowth pattern, or how did you describe the ossification pattern that you saw with that biomaterial?
I think it showed, I have to check back, but I believe it showed similar results to that of the autograft control. So what we saw was it was a good alternative to use of autograft in the rabbit model.
And then what was your lumbar fusion model, and how many patients did you have, and what was the control group?
In the case study that Dr. Stark just presented?
Yeah, if you go back one slide, Dr. Stark. So there was a reference made, so in lumbar fusion, so clinical data 19 and clinical data reference 20. What are those studies? What was the N?
So sorry, could you clarify that question
We
again?
have two references given, clinical data, reference 19, 31 patients. And then clinical, sorry, next slide is it's 20. So we obviously don't have this immediately available. So how many patients were in reference 20 and what was the control?
So reference 20, the BMP, so this was our health economic study that we did. We utilized the Premier database and looked at a lot of the coding and obviously the outcomes. The BMP group is in the tens of thousands of data points, whereas the FIBERGRAFT group is in the thousands. So there's just BMP has been around for longer, so there's more historical cases that we could look through. FIBERGRAFT, on the other hand, hasn't been around for as long. So that's the sample sizes at least, right? So we're looking at tens of thousands and then thousands.
And the prior slide 19, that's not yet published, I assume. So this is 31 patients. So yeah, so that's obviously a little bit difficult to draw extrapolations.
Right.
We look at those numbers there because again, those are
Of course.
on the power calculation, just offhand, probably pretty low numbers. So it's more incidental to see these percentage differences, right?
Yes, of course. And, you know, we obviously recognize that this is a newer product and we're starting to build out the clinical data. This is the first abstract that we were able to present at CNS. We do have another one coming that just finished earlier this year. And then we've also begun a prospective single arm study for Iridian Matrix specifically. So we're just enrolling right now. And it's something that we're really looking forward to, as we do believe that this new biomaterial is kind of on the forefront of synthetics.
So since we have the benefit of a scientist and a scientist surgeon, how do you suggest we prepare this graft? Do we soak it into autologous blood? Do we spin something down? Do we mix it 50-50 with autograft? What's the suggested optimal deployment method?
So at least strictly speaking on the indications perspective, when you're using it in posterior lateral fusion, combination with BMA and autograft.
So 50-50 or what's the ratio? Dr. Stark.
Yeah, so I mean, how I use it, with VTOS, you had to mix it with bone. I typically mix it with just bone from the autograft, mix it all together with that, and then mix it with some of the blood from the field. I don't necessarily take bone marrow aspirate, out of, the pedicle or anything, but that's the blood that's bleeding into the field and things comes in. So I just mix it all together and then I just lay it down.
Okay. Got it. All right. So let's go into your case examples. Thanks for those
No problem.
detailed reviews.
Yeah, and these are just going to be two kind of quick cases just to show kind of my use. Again, I've only been using this for right at a year now, so I'm just getting my year-end data. So the first one was a 20-year-old girl who presented after an MVC polytrauma. She had a complete spinal cord injury from an L2-3 chance fracture, unfortunately. So she had no sensation, no function in her legs. She had multiple abdominal injuries. So this is just her, initial imaging when she came in, showing kind of the chance fractures through that bottom of 2-3. And then this was, I did a 2 above, 2 below construct, and you can see just the complete osseous fusion here. And this is at her 1 year post-op. So I did her October of last year. And then this was, her most recent. She's a young girl. So I went in and took her hardware out after we had this, showing a complete fusion. So pretty significant fusion. She's young, so that's the easy one, right? So
Don't go forward.
Yep.
So just curious, I literally just got sent a case like this from an outside country from a former fellow of ours. So this is a flexion distraction injury. I think we can all agree it's a B2.
Yep.
So the question I have is how much neural decompression do you do here? How much do you repair dural sac? Because this is a young patient. This is an infraconal injury. So how much time do you spend on neural decompression and repair of possibly torn dural structures?
Yeah, I mean, I did a wide decompression from, basically the bottom of 1 to the top of 3. Her dura was, of course, shredded. The nerves and things were kind of coming in and out of the dura there. So, I stuff them back in, and then I do try to close the dura, or so a graft in to close the dura. So I do actually spend a lot of time with that, just to make sure I get a good closure, and give them the best chance. She has regained a tiny bit of sensation, I would say. It's only been a year, but I don't expect her to get much more motor, because her conus actually ended, pretty low at the bottom of 2.
Oh,
So
wow.
she had almost like a tethered cord. So unfortunately, the edema went up pretty high. So yeah,
So this is a true
unfortunate for her.
lap belt type injury mechanism, right? So lap belt injury
Yep.
mechanism.
Yep. And she had an
yeah,
aortic injury. She was very lucky. They didn't have to do any surgery for that, but she did have, a open, X-lap, because she had some abdominal injuries too, spleen, things like that. So
we don't see those that much anymore. I actually published on that in the whatever 90s or so, but these lap belt injuries are terrible when there's no shoulder strap, and they have a high concurrence of intra-abdominal and vascular injuries. And the neural element injuries are traction injuries, which have a terrible prognosis. And her bad luck would have it that she has a conus that's low hanging, so this is even worse. So this looks very nice. So why did you not fuse her down to L4, just out of curiosity? Was it just to preserve maximum motion, or?
yeah. Yeah. So I put extra points of fixation, one just because of the degree of the Lamy I did, but I didn't want to necessarily fuse at 4, because then, she's got 4, 5, and 5, 1 with this long segment. So tried to leave her a little bit extra mobility. She's young. She was, I think, 20, I said. So
Yeah, great. What's the role for a follow-up MRI now that the hardware is even out? So do you get follow-up MRIs to just check on blanching or further compression of conus, et cetera, pseudomeninges, et cetera?
I did do an MRI on her, a few months out from the surgery, actually. I don't necessarily do that if patients are, improving or stable, but because she was an Asia A, she hadn't got much back. We did do one. She had a wide decompression. Everything looked good. It was just, originally her conus was so low, that she had a pretty severe injury there. Her boyfriend actually died, the guy that was driving. So
Yeah, it looks absolutely like a terrifying injury and beautifully done.
yeah.
All right.
Well, thank you.
Okay, we're ready for more.
So last one is, someone that you kind of worry about how they're going to fuse. So a 69-year-old guy, he presented with central cord syndrome, myelopathy, he had severe cervical stenosis. He was a stage 3 kidneys. He wasn't on dialysis yet, but he was kind of a stage 3 kidney injury. Had been a drinker for a long time. So I did a C2 to T2 on him, kind of in an emergent setting here. And this was actually only 6 months post-op, and I'm not really sure why, but he fused very, very well, despite being a little bit of the older, population. So pretty remarkable at 6 months. You can see there's a little bit of non-fusion here at this one joint. Maybe a little bit here at 7-1. But overall for a 6 months, that's pretty good. And, I'll have his next follow-up 6 months in, about 3 more months. He'll be at a year. So it'll be good to see. But, he's doing very well, still myelopathic, from the original injury, but was actually went to rehab and is actually able to walk and everything now. So it's pretty remarkable.
So the question, if I can be critically questioning, can you go back one? Is why is there an empty screw hole on that one side? Is there osteolysis around the screws in the bottom? So mainly that center image. So just I don't want to be that I'm not. I'm just curious what's going on there.
Yeah. So he had a previous. So you can actually see the connector here. He had a previous fusion below. So those holes were pretty big. I did upsize them. But I couldn't go much bigger because of the pedicle size, but just put down bone graft kind of to connect down to his previous thoracic. He'd had a thoracic trauma. It's not the most reliable guy. So
no, it looks nice, nicely done. And yeah, that's obviously one of those myriads of aggravating factors. So if I was to advise a company on having the ideal proof for bone graft substitutes working, I would use exactly this model, a multi-level posterior decompression fusion. And I would tell the company, I'm going to put all of your grafts with whatever recomposition you tell me to do on one side, and I'd use local bone graft on the other side. And I would then get a post-op CT like at 6 months later and compare those two. Wouldn't you say that's a really clean way to look at it? There's always some mechanical interference. Yeah, so for me, this is for the company people who listen. If I want to prove my fusion, I would basically put my eggs in, quote, one basket and my standard of care on the other side, and then just see pure maturation, realizing that there's a biomechanical interference. So
Yeah, I think that's a really good point, and a really good way to look at it if you wanted to do a study on it for sure.
talking about this, so what is your standard postoperative plan in terms of postoperative scanning for patients when you've had fusions? Do you get a routine CT at 6 months? Dr. Osku and I right now reviewing a proposal from a different company. Name doesn't matter here. But again, they want us to get CTs like every 3 months, and
No.
it's not the standard of care. So
No, I do, I think pretty standard. I do 6 weeks, 12 weeks, 6 months x-rays, and then at a year I do a CT scan.
Okay, but you
That
routinely
guy came in for a trauma. The second guy again came in after a fall. He was drunk and fell off a bar stool. So that's why he got a CT scan. So it's just helping me out because he already had a CT scan.
So if you can go back to your boron slide. So boron is one of those, what I've seen in the bone graft world is there are a lot of new terms floating around, from nano, meaning size of particles, to structure, meaning crystalline, to electrical precharging, to minerals. So there's a lot of terms being thrown at us, and especially me, an older generation dumb surgeon. What do all those various things mean? So zinc and magnesium, I think the common population would think like, oh, that's good for infections and that'll keep me quite enough healthy. But boron and copper, that raises kind of a little bit of a suspicion. Is there systemic load on these patients? Does this actually go into the bloodstream? Would this be measurable?
I'm gonna see if Bobby has an answer
You
for
want me
that,
to
'cause
jump
I
in
would
here?
assume it does not, but yeah.
Yeah, obviously, like you said, zinc and magnesium, very well known. So my background is tissue engineering, so if you kind of read up on the literature specifically to bone, these four elements are really starting to get hot, specifically copper and zinc for their infection properties. I gotta say that we haven't tested iridium as anti-infection, so I'm not saying iridium does that, but when you do look at these elements from a literature perspective, you're starting to see that in vitro testing. Boron specifically, when you compare boron to other silica-based bioactive glass materials, whether it's 45S5, S53P4, which is the other formulation, the reason boron acts so much faster, like what Dr. Stark was saying with hydroxyapatite formation, is because the structure of the boron particles is much weaker than that of silica bonded particles, or elements, I should say. So it just breaks down much faster and releases these ions much faster than your silica-based products. Copper, on the other hand, there is some anti-infection type of characteristics to it, but one thing in particular that is in the literature is angiogenesis, so stimulating blood vessel growth within the constructs, right? So, I think, of course, a lot of the literature is in vitro based. There are some in vivo studies, obviously, in animals. I think that, I would love to have confirmation in humans that it is that, but that's why we have to say everything with in vitro and in vivo, because we're never going to excise a piece of someone's bone to see, oh, did we actually, enhance blood vessel growth? And then what's the control of that, right? So, unfortunately, there's only in vitro and animal study evidence to support it. So that's kind of the background. I'm not sure if I answered your questions specifically, but feel free to build on what I said.
It's what I'm hearing here is that we have some suspicion that it helps contribute in the ways that are identified on the slide, but human confirmation is not quite there. And I assume that the safety of it is somewhere assessed, regulated, understood. Is that correct?
That's correct. Yeah. The boron, these borospheres are an iteration on your classic bioactive glass products, 45S5, S53P4. Those previous bioactive glasses have been well studied. When you search 45S5 bioactive glass on PubMed, you'll come up with 700 different articles, not just spine, across all orthopedics. And it's very well studied. And with these boron bioactive glass particles, obviously with diffuse synthes being associated with Johnson & Johnson, they would not allow us to sell and use this product in humans. We had to go through, even though the product was approved by the FDA through the 510(k) pathway, Johnson & Johnson had to do its own assessment on the safety and efficacy before we were able to use it in a person, right? So there's a lot of safety evaluations performed on this product in particular.
And not beating a dead horse too much. So I've obviously, as an older surgeon, seen and been through everything imaginable, and I'm sure there's more to come. One thing that has troubled me in these kind of substitutes is the potential that they actually look pretty osteodense on X-rays, but then when you get in there, it's basically just a gristle. It's more or less something
100%.
that poke apart pretty easily with a neural dissector rod. You've seen that. We've actually had some cases like that where they look like there's something radiodense posterolateral, so, and then you start digging around and it's just like sand. It's,
I mean, honestly, even, people talk about BMP, Jens and I have gone in cases where it looks like bone on CT, but then when you go in, it's like, you just tap it, it's like eggshell. So it's not the same. Obviously bone formation is very complex. And so I think, there's not when you say it's fused on imaging, that can be different for different situations.
Yeah, I totally agree 100%. And I think even the definition of fusion is not standardized across the industry, right? So I think that is a 100% a fair point. Right. And, I think X-ray is definitely less reliable than that of CT, but even when you CT and if you were forced to go back in, it doesn't show the full picture. Right. So I definitely agree with those statements for sure.
we sound like skeptics. I learned a lot. For instance, this slide here with those 4 elements, I would have, had this been given to me as a multiple choice test in a board setting or recertification setting, I would have not associated those, I must say. So I learned this thanks to this presentation. So thank you for that.
Yeah.
I'll tell people to go on zinc supplements and go down to clinic and I'll see 30 patients. I'll tell my fellows, put them all on zinc and magnesium supplements. The boron copper, I don't know. Maybe wear copper gloves. I don't know about the boron yet. So, but no, these are important points, and this just expands to our knowledge how complex bone healing is. Mm-hmm. I always tell our fellows there are 2 types of human beings, and sadly, we as human beings differentiate one another on many different fronts. But what really matters for us is they're bone formers and they're non-bone formers, and helping those who are non-bone formers get to a reliable bone healing is a very, very important factor. And this definitely adds to our armamentarium of understanding of what all to look for. Dr. Stark, in your practice, let me go into something tangential that is so important for us, nutrition. So these all are kind of fine and dandy, but how does sarcopenia and how does malnutrition factor into your assessment of trying to optimize a patient's recovery?
Yeah, I mean, obviously, a lot of the patients that come in, especially through the ER, are not the healthiest, as in like this guy. So, we do like to send them to bone health clinic if we're doing an elective case. It's like a big fusion scoliosis kind of, procedure to try to get their bone health better. When they're in the hospital, we try, especially these people who are very malnourished, try to get them to start taking the Ensure. You could see a significant, not just in the wound healing, but in the ability to form bone. I mean, if they don't have protein, if they don't have these kind of nutrients in their body, they're not going to heal both their incision, nor are they going to fuse. And, that's the biggest kind of problem we have now. If you throw BMP down, they probably would, but, that's what we're looking to kind of replicate without the expense and without some of the other side effects of BMP, right? So.
This is, I think the cases that our fellows showed all had one common denominator. They were severely, if you look at the MRI, severely sarcopenic, that significant mottling of their paraspinal muscles. In the lumbar area, there was almost no psoas left, so they're all severely impaired. And again, on the patient that Dr. Kramer did so beautifully with the multi-level laminotomies, that severely ill patient, I can only imagine how significantly malnourished and protein impaired this patient is. So for me, this is one of those many variables that are thrown in. Then when we look at series of patients with fusions, I would like to know these things like sarcopenia A and what is the nutritional baseline. And sadly, we don't have simple nutritional baseline tests outside of albumin. So I think this was a very helpful discussion. I appreciated also your insights into our cases. Dr. Kramer, any thoughts from your end as a young surgeon?
No, I'm equally learning, about all these different factors, and as I'm starting my practice, I'm certainly interested in whatever I can to improve fusion rates. So I appreciate the wonderful presentation.
Rod, any final closing statements?
Yeah, no, I mean, this is awesome. I think, thanks, Jessica, for presenting. And, I think this biologics, presentation in terms of, for me, like just even all the different ions involved, I think is really cool to understand and learn more about it.
Right. With that, Dr. Stark, we thank you for your time. We thank DePuy Synthes for their support for this program today. And it's always fun to talk to colleagues from different spheres. We definitely want to have you back here, Dr. Stark, and review more cases together and draw from your experience in the great state of Texas and Houston. So have a great day.
You as well. Thank you all so much. Appreciate it.
Good to see you online. Thank you all. Bye-bye.